Welcome to another episode of Between Doctors and Friends. We have here Dr. Foz with Primary Care. How are you doing?
Hello. Doing well. How are you?
Doing well. And we have Dr. Ray, an OB-GYN. How are you doing, Dr. Ray?
I'm currently in the hospital. I'm here doing a 24-hour shift covering all pregnant women and deliveries. I started at 7 a.m. and I'll be here till 7 a.m. tomorrow. I've done one delivery so far and I have at least 3 more to go.
Wow. Okay. And have you had breakfast? Are you like lunch hour? What's going on?
I actually haven't eaten anything yet. I thought I woke up early, to come here, and I thought like, okay, as soon as I got here, I'll go ahead and maybe get something to eat. But then, as soon as the other doctor signed out to me, I got called to go deliver a baby, and she wasn't ready. I pushed for about 30 minutes with her, and she wasn't quite ready. So then I left, and the cafeteria is a little further away, so I didn't think I had time to go to the cafeteria in case they called me back. And so I just went and saw some other patients, and then I went back to go deliver her. And then I went and did my rounds because I was having the nurses calling me. Some patients were getting anxious to go home, so I went and I did my rounds. And then about 10:45, I started getting a little hungry, and I was like, oh, I'm getting hungry. I should go get something to eat. But then I was like, well, no, I cannot because the world of podcasting is calling my name and I need to go do my podcast.
And for your highness. Absolutely.
So that's where I am right now. So as soon as this podcast is over, if I don't get called by a nurse, then I will be headed straight to the cafeteria at that point, will be lunchtime where I am.
Well, you look at
the life of a doctor, especially an obstetrician.
Yeah.
Like, you don't get anything that you need.
Wow.
Yeah. So I had
everybody
one
else
glass of water
you.
today, and that's it. So hopefully I will be able to get some lunch at a reasonable time.
Can't you can eat while, you're doing a podcast?
Yeah, if I had planned better and had some food with me, like brought some food, but I was just tired this morning and didn't really wake up on time to think about everything that I needed. I just brought my overnight bag and that was it. And I didn't think about bringing food or snacks because usually the nurses' stations all have little snacks and everything. And, I've already been offered back in the storeroom. One of the storeroom clerks brought her homemade salsa and chips, but she offered that to me at like 8 a.m. and it wasn't. And I was like, not feeling salsa and chips right now. I'll stop by a little later. There's going to be food there. And then there's always food in the doctor's lounges. And then we have a cafeteria. So I'm not missing food. I mean, I'm not short on food. I just short on time to be able to walk to where the food is because I had that patient who was delivering and then I had to go see the other patients who wanted to go home. So I'm just being called in different directions. So I don't have the time to go find the food. There's food to be found. I just haven't found it yet.
Shout out again to the nurses who always feed the doctors on the floor. Because they take pity of us. And they'll be like, honey, you look like you need to eat. Here, eat this. So motherly. Yeah. I love it.
Yeah. Wow. So there's always something. The nurses are never short on little snacks at their stations. They're very much more prepared than the doctors are. So they've brought their supply and are always very generous. And oftentimes, I don't know if today, but oftentimes, especially on weekends, the nurses will do like a potluck lunch just to, everybody to lighten the mood and have a little, fun. So that's always something to look forward to.
For those of you watching our podcast, this is our very first video podcast. If it works out, we will be cutting.
If it works out,
hopefully Dr. Ray can, turn on her camera and bring us to, no, she can't.
No,
but we'll cut some stuff during this recording so that Dr. Ray can take care of her patients in and out.
I have to say, I feel like I always joke, if I could wear a camera through my day, it would be the most hilarious reality show ever.
Oh yeah.
HIPAA.
Yeah, exactly. I think, I mean, I really think my life should be a reality show as it is, but, but yeah, I can't reveal anybody's identity or anything.
Well, would you look under that blanket?
Yeah. Ooh, I see a hand up.
Yes, I just want to comment. I actually want to see this reality show, so we need to where are the lawyers? Where's the loopholes? Can we change the names? Because I want to see.
Let's make it happen.
I don't think you'd believe it. I mean, I think you'd be like, you got to be effing kidding me. I think I think the average intelligent person would just be like, really? And you're like, yeah.
Yeah.
Wow. Well, I'm just gonna go straight to this so that we get Dr. Ray, talking about this. I will share my screen of cryptic pregnancy. Let's watch a little bit of a video of this.
A medical marvel. Susie Lopez went in for surgery at Cedars-Sinai to remove a more than 20-pound ovarian cyst, but came out holding the very child who never knew she was carrying.
I knew that I was pregnant for about 5 days.
Very good. The standard pre-op pregnancy test revealing the shocking discovery.
I wasn't even believing it at first because I have ovarian problems, so I was thinking it was like a false positive.
Susie giving her husband Andrew the good news.
I thought she was joking, and it didn't really sink in until I actually got a little gift from her, and it was at a Dodger game. It was surreal.
Doctors ordering an MRI and were stunned at what they saw.
He was located outside of the uterus, posterior to this big ovarian mass in the abdomen. So his head was up on the left side of her abdomen under the spleen. And it makes sense that she didn't know because the baby was in her abdomen behind the mass, and it just looked like the mass was growing.
Susie had what's called an abdominal ectopic pregnancy, extremely rare and life-threatening for both mom and baby.
He's still very sick.
You okay?
And we're needing to do a lot to support him.
On August 18th, a team of 30 medical professionals removing the giant cyst and delivering the full-term baby named Ryu.
Hi, Ryu.
Weighing 8 pounds and in remarkably good health.
How are you today? Good morning.
I love it when they come out with a full head of hair.
Yeah.
That's awesome. It's like, where did you get all that hair?
Oh, I just have to ask, Dr. Ray, were you looking at this clip and did you roll your eyes during the? Because I just kind of remember how you
Yeah, no. So this is a very different situation than a previous conversation that we had. So this situation is incredibly rare, and yeah, a lot of the OB doctors that I know have, in little chat groups and everything, have kind of talked about this and everything. So this is a patient who had a very large ovarian tumor, and that was the reason why her belly was growing, and the reason why she assumed, and the doctors assumed, that her belly was growing because she had this very large tumor. I'm not sure when she first came in to be seen for it, or if she just presented when she was quite large with the tumor, because obviously if she had presented much earlier in the pregnancy, some imaging and studies would have been done and would have discovered the pregnancy. So it sounds like she may have let this problem go until it was so large that she, and she was being affected by it so much. Then she came in to the hospital, and that's when they did the MRI and realized that not only does she have this huge tumor, but she's also pregnant at the same time. So now this ectopic pregnancy, which basically means that a pregnancy is not located in the uterus, it can be located in the tubes or the ovaries or the abdomen. It's incredibly rare. I don't know what the statistics are, but it's like a 1 in a million chance. And usually with any ectopic pregnancy, because it's not inside the uterus, it does cause internal bleeding, and those patients present to the emergency room hemorrhaging internally and very unstable and needing urgent surgery to be done. So it's quite a miracle, to be honest with you, that this abdominal pregnancy, progressed so much so that she had a live baby, because ectopic pregnancies do not end in live babies. Another thing that the medical community could not figure out, that they didn't release as far as I know, is where the placenta implanted, because that's a huge curiosity as well. And the placenta has to implant somewhere, and the blood supply to the baby is from the placenta. So I'm not sure, since they mentioned that the baby was behind the spleen, I'm not sure if the placenta embedded into the liver or where it was, but it obviously embedded somewhere where it did not cause a hemorrhage, getting the blood supply and food from the placenta. So it's quite a miraculous situation, to be honest with you.
Do you think that I've never heard of a ectopic pregnancy, regardless of where it is, ever going to a viable delivery. And I can't imagine that a placenta can implant somewhere that wouldn't have like serious bleeding issues, that wasn't intrauterine.
Right.
Do you think this was just a completely like it's an intrauterine pregnancy, but it's just really displaced? In other words, like because of the large tumor, instead of growth, typical, it's the poor baby squished up into a corner, the whole uterus is kind of squished into a corner, because that's the only thing I could think of that would allow this to occur.
They said in that video that the baby was out in the abdomen. So I've never heard of a ectopic going to a live birth either. All ectopics that I've ever seen or read about have always ended in some kind of surgical, emergency or something, never have grown to term. That's even when these politicians have started to interfere in women's health care. A lot of them are preventing services to be given to patients with ectopic pregnancies, because they'll say that, the pregnancy's in the tube, but we still see a heartbeat. And I believe there was even a congressional hearing where one of the congressmen said something like, well, can't you just take the pregnancy out of the tube and put it back in the uterus? And the collective,
what a moron.
Rolling of the eyes, from every obstetrician is like, it just does not work that way. That is why you politicians who have zero idea or information about how anatomy works should not be making any of these laws. So yes, ectopic pregnancies are usually never viable. That's why I said this is an incredibly rare situation, and quite a miracle that baby survived. So this is a very, very rare situation. Now, a previous conversation that we had were the women who have normal pregnancies, the baby inside the uterus, but just state that they never knew they were pregnant until they went into labor. So they go 9 months of being pregnant, not knowing that they're pregnant, and then all of a sudden they're in labor and they have a baby, and they're just like, oh my God, I never knew I was pregnant. That's more of the definition of a cryptic pregnancy than what this video clip and what this patient experienced.
Thank you. I just learned a lot.
Yeah. I would just reading the video, and obviously I will always defer to Dr. Ray, but I think the way that it was described is that, the baby's up underneath the spleen. I'm sure it was inside the uterus that was displaced from this huge tumor. Like there's no way that this was an extra uterine pregnancy.
Right. So they don't go into too much details, again, because of HIPAA stuff. And, maybe one day they'll write it up into a case report and put more of the scientific information into it, which is what, the medical community is more interested in. So it really is a matter of was the uterus just displaced? Was the baby actually outside into the abdomen? Where did the placenta implant? All of that stuff. So it's a really interesting case, and these types of cases you would see oftentimes in third world countries. This is not something that's prevalent here in the U.S. type of a situation. So pretty rare and pretty amazing, actually.
I would totally yeah, this is really wild, and I would totally agree with you in that this patient presented late. Like, this patient probably came into the emergency room because of severe pain or something, and that's where everything, they said, a routine, there was something about a pre-op pregnancy test or something that was done routinely. Well, that probably happened when she presented in the emergency room, And that's the other thing too. It's like, this isn't something that doctors would be like monitoring her and talking to her about, because there's always a discussion of menstrual periods when these things happen.
Right.
It's like, okay, when was your last period? Okay, it's not when it was expected. Okay, pee on a stick, please.
Yeah. And I think in the ER, one of the first questions they ask every woman is when their last period was. And one of the most common tests that they run on every woman is a pregnancy test. So
100%. If you come into my clinic and I'm not certain you're not pregnant, depending on what we're talking about, you're going to pee on a stick. Like, I just need to know where you are right now, for sure.
Yeah. Yeah. Yeah, because you go down two different pathways, once you find out one or the other.
Right, because that's positive. You're going to go see Dr. Ray.
Us that, yeah. But I also remember them.
Leave me alone.
I also remember them. Yeah, exactly. In med school, them telling us that, every woman of reproductive age, you have to almost assume that they're pregnant before you start any kind of treatment on them or do anything.
Oh, yeah. I've definitely caught pregnancies early when women didn't know. They're like, oh, I'm pregnant. And I always ask about contraception whenever we're dealing, okay, I got a chest x-ray. When is your last period? Okay. Are you trying to get pregnant? What are you doing to not get pregnant? What's the situation here? Because they'll tell you that they're not, but they're not using any birth control. And you're just like, okay, are you trying to have a baby? They're like, no. And then I'm like, well, then you are.
Yeah.
So take your folic acid and go pee on this stick.
Yeah. Yeah, I always tell them when they're not taking their birth control, I said, you're either trying to get pregnant or you're trying not to get pregnant. There's no in between. Because if you're not taking birth control, then, and you're having unprotected sex, then you're going to get pregnant. So what is it that you want to do? Do you want to get pregnant or do you not want to get pregnant? And then we need to figure out how we can help you with either of those.
Oh, and it's so funny too. Yes, agreed. And then there's the whole, what kind of birth control are you using? And then I get all this vitriol, angry people. I don't like birth control pills. I don't know why you're talking to me about that. I didn't ask you about birth control pills. I asked you about contraception and birth control. Like things like abstinence is birth control. Condoms is birth control. Like I didn't say birth control pills, did I? Ding-a-ling.
Right.
Look, the ding-a-ling is how they got there in the first place. But okay.
Yeah. Exactly. So yeah, that's the issue. But as far as these, women who think that, or women who don't realize that they're pregnant, and then go into labor, I definitely have a hard time believing a lot of their stories that they say, because it's very hard to not know that you're pregnant. Pregnancy is very uncomfortable. There's a lot of aches and pains involved with it. There's, back pain, swollen feet, difficulty sleeping, and there's a baby moving inside of you. So I'm not sure I ever really believe these women when they say that they're not pregnant. I think there's a lot of denial, and probably that denial is so strong that they convince themselves that there's no way that they're pregnant. I've not had a patient come into my office or my labor room that they didn't know that they were pregnant. I've had maybe at full term, I've had patients that have come in maybe second trimester and not realize that they were pregnant at that point. But usually by the time they hit 20 weeks, they can feel the baby move. And I feel at that point, you have to believe that you're pregnant. But like I said, I think a lot of people are in denial, and that denial and that fear that can really psychologically affect you and just make you think like, no, there's no way that's a possibility that I could be pregnant. So I know there are a lot of stories, and a lot of people will have, internet stories about somebody who just like, I didn't find out I was pregnant until I pushed the baby out, kind of a situation. But I don't know. It's as someone who's been pregnant, it's hard to believe that you don't know that you're pregnant.
Denial's not just a
Dr. Foss?
river in Egypt.
Yeah, exactly. Yeah. So, and then we've all seen pregnant women. They look very obviously pregnant, I think sometimes that that some people, maybe who are a little overweight can probably hide it better and not let people catch on that they are pregnant. But like I said, you feel it, you can tell, when you're pregnant. Have you had any situation like that, Dr. Foss, come up? You don't really see a lot, but
Never. I mean, I've had to break news that guess what, you're pregnant. But it's always been early pregnancy. I've never had anybody walk into my office like, way into it going, my belly's growing. What do you think is going on?
Yeah. Yeah. I again, like I mentioned, some of these ovarian tumors can grow incredibly large, a size of a basketball, and those women can definitely look pregnant. So when I was in my residency and I had a different population, a less socioeconomic status population who didn't have access to um, to medical care and or newly immigrant population, especially from maybe Africa or Asia, I would see a lot of those patients come in who looked pregnant, but they had huge ovarian masses and needed surgery to be done. And a lot of times when I would talk to these patients about how long has this been going on, how long has this been growing, and they would say months and months, and they, would just have been in denial at first that they just didn't really think anything was going on, but then it was getting bigger, and then they didn't have access to care, and then they didn't want to come in, and then they were scared to come in, but whatever triggered them, today usually it's some kind of pain episode, that's what then brought them in. But as far as so I have seen quite a bit of people who like we thought were pregnant, like you look at them and your first thoughts were that, oh, they're pregnant, but then when you do your test, so I see these women who have, the large ovarian tumors, and then they look pregnant, but they are then found to not be pregnant. So this woman who came in that video, she must have, maybe because they missed it, then she thought that she wasn't. So it's an interesting situation.
I've seen women with large uterine fibroids that you can see from like the outside from their bellies. I'm like, yep, they look pregnant and they're not,
Yeah.
But
yeah,
that's it's I think it would be really hard for a pregnancy to progress to term essentially, and for somebody to not have a clue. I mean, I think that would be really unusual.
Yeah.
Is there a question? I see a hand up.
So is it inappropriate to approach a woman and ask when they're due?
In this society, yes.
You never know. I mean, especially a lot of like newer moms who have given birth, they still sort of have that little pooch. I still have my pooch, so.
I think in this society, I would not do that.
So before we continue, I just want to give credit to ABC News and Yi Jin Yu for this article. A screenshot of the operating room It's a lot of people in there.
Yeah, well, they mentioned that they had a team of over 30 people.
Yeah.
Yeah.
You could do that?
So, okay, yeah, you can definitely, I mean, for these very difficult, complicated surgeries, you need a team that big.
Wow.
So what's going on is, one, they have to deliver the baby. So you have to have a obstetrician in there who can find that baby, deliver that baby. So probably 2 obstetricians are in there. Then second, you have a large tumor that this patient has. So you need a GYN oncologist, which is a doctor who specializes, a gynecologist in female cancers, and especially ovarian cancers. So you might even have 2 GYN oncologists there. And then you need to have all the nursing staff as well. And then, like I said, that placenta is implanted somewhere in the abdomen. And so you probably need general surgery, vascular surgery, maybe even trauma surgery because she might bleed a lot. So you probably have, maybe 6 surgeons. Then with all the ancillary staff, the nursing staff, the surgical
pediatrician,
tech,
the
the
NICU
pediatrician for the
doctor,
baby, the NICU doctor for the baby, because you don't know what that baby's condition is going to be. And then, if she's going to need blood, you have the people from the blood bank.
But it feels like there's so many there. Is it just they're standing around, so if they need like that team, they could just like scoot over and...
Yes. So I'm going to step in here because Dr. Ray was called for a delivery, so she's not available at this point. Yeah, there's operating theaters, they're not going to put this person in their smallest operating room. I can guarantee you that. And people move out of the way if necessary, and there's generally, they'll make it work.
Okay. Because I'm seeing the people in the back kind of like, I can't see.
Well, they're not all going to be on there at the same time. And then, like I said, there's whoever the primary operating physician is. So it's probably an obstetrician with their assistant. There's going to be, the gynoncs, probably, like she was saying, general surgery, possibly trauma surgery. Definitely the neonatologist will be there with their with their nurse. Then there's going to be like the circulating nurse. There's going to be a technician, a scrub tech, and there's also going to be the anesthesiologist. So there's going to be a lot of people in that room, but they know what they're doing. They know how to make this work, and hospitals know how to do this. Like, things like operation staff, they know how to make these things happen. I see a hand up.
Yes. Sandra, what's up?
I wanted to know, what about if it's, I'm going to refer to my only a hospital knowledge right now, the Pit, and it's a teaching hospital, and they have students there kind of taking
totally.
notes.
Residents, students.
Now, would that team be much larger for, even if it's not
wow.
Okay.
Yeah, you're going to have, right, and you're going to probably have some people, especially if it is a teaching hospital, that are going to be on this case just to observe, because it could be so groundbreaking, and it's not negative for the patient. It's not like anybody's trying to violate her privacy or, it's not juicy. It's just that it's medical knowledge. It's like, I'm going to get to see how we handle a case like this, it's about learning. We have to learn from each other.
Wow.
And she may, they may get consent from her down the road. Can we write this up as a case study, or even not? You can discuss medical information for professional use, that as long as it doesn't involve any protected health information, so identifiers for the patient.
Okay. I mean, I think if it was a teaching hospital, I would assume they have a lot of step stools.
Yeah. I mean, a lot of teaching hospitals, they have true operating theaters where there's observation seats above, and there's just a lot of people in there, and I've been the student on these things, so I would hope there's some students and residents in there because they're going to get to see really fascinating medicine that can help them understand pathology and how to do things properly so that they can take that information and move forward and apply it to their own patients and give their own patients in the future excellent care.
Wow. This is great. Any other questions, everyone?
Just one. How many? Like, what was the largest room that you've been in personally, Dr. Five? Like, how many of the medical team was it? Was it 30 or was it more than 30?
I'm just trying to think. Probably on the order of maybe 20-ish people.
Nice.
Wow.
I'm just amazed right now.
Well, remember, I'm also not a surgical doctor, so it's not my forte nor I'm not like, hey, that's a really cool case. I'm just like, whatever. It's just, I have to learn what I need to do, and it's not that I don't find it interesting. I'm not a surgical physician at all. And so, I'm not spending a lot of my time, like when I was in training, doing all kinds of surgeries. Whereas Dr. Ray, after she finishes her internship, part of her residency, she was in deliveries in the operating room a lot, and then also in the clinics, but it's different for every specialty. So surgical specialties are going to be in the OR a lot. I see another hand.
Sandra? Sorry, I couldn't find the mic button. Can a patient do they have to opt in to have
Yes.
to have an audience?
Well, this is not an audience. This is the care team. So the medical student who may be in that room is going to be rounding on that patient the next, that afternoon to check on them. So they're part of the care team.
Okay.
Now, they can opt in a teaching hospital. You can opt to not be cared for by residents, interns, and fellows. I don't want to deal with anybody in training. But, I think on the patient side, I think it can be certainly frustrating because the medical student comes in and asks you a question, and then the intern comes in and asks you the same question, and then the resident comes in and asks you the same question. Now here comes the fellow, and then, okay, now finally you have the attending with everybody. And so everything is like, didn't I just tell you this? But please understand too that when you have the privilege of that, you have instead of one set of eyes or two sets of eyes looking at you, you have 6 or 8 sets of eyes who are trained and interested in your care and how this is going to go and how can we optimize this situation. And everybody has an input in all the things. So, if I have something serious or concerning, I absolutely would prefer that because you have many minds trying to see what is best for you. You're not a guinea pig. You're a patient, and we are working together to make sure the outcome is as ideal and straightforward as possible. And so, none of this is out of it's not out of just being, I don't know. There's nothing.
It's not for social media.
Yeah, it's not. It's not for just morbid curiosity, if that makes any sense. Yeah. It's out of medical curiosity. If I have somebody who's had an interesting rash or something, oh, check this out. I'll grab my colleagues and be like, you want to see this? I've never seen it like this. And they're like, oh yeah, that's weird, but we're not doing it so that we can, look at that ridiculous patient. We're not, it's all about hey, now I've seen it look like this. And now if it comes around, my colleague who saw it in my patient, will now be able to hey, now I'm not going to miss this diagnosis or I'll understand this disease better. So we have to learn. And it's a lifelong learning. And these poor students and interns and residents, they got to start somewhere also.
That's true. That's true. Well, we're going to change topics here because, hey, this is the reality show. Dr. Ray, we got a text saying delivery.
Yep.
That must be how it is.
And I hope she can then have lunch, poor thing.
I know. Or otherwise she comes back and goes.
Or dinner, or whatever.
Tell us about the tell us about the delivery. All right, let's change topics right here.
Not a food delivery. Yeah.
Not a food delivery.
Wrong delivery.
Delivery. DoorDash. Um, all right. Change of topic. Dr. Foz, blood pressure versus pulse.
Okay.
What's the difference? And I just grabbed
Okay,
this
so
image online
please
and
get that image off that screen.
all right, why? Tell us why. Tell us why.
Because pulse should technically not vary by age.
There you go.
It does in a pediatric population. So kids, like young children, are different. So infants versus toddlers and stuff are going to be a little different than your average, 39-year-old. But outside of that, pulse in adults does not vary. So pulse just basically refers to the rate and rhythm of your heartbeat. That's it. And there's a normal rate and there's normal rhythm.
The rate and rhythm of your heartbeat.
Mm-hmm.
All right, Sandra.
What is the range for unusually low pulse?
Pulse.
Is there a range?
That is, yes, but see, there isn't, like in a lot of medicine, there is not hard and set rules, right? So you can have people who have pulses that run outside of the average normal range, and it may not represent a particular problem. So a normal pulse in an average, asymptomatic, healthy adult, that's what I have to say, right? Because it's different if you're sick or if there's a problem, is 60 to 100. So that's the average range. But you can have people who have, you can have athletes, people who are quite well conditioned. Their resting heart rate will be 48, 50, not that weird. You can have certain medications that can drive the pulse down. If people are on medicines like beta blockers, a type of heart and blood pressure medication, you can drive it down. When 100 years ago, back in my running days, I had a resting pulse of like 49.
Wow.
And there was nothing wrong with me. And then there is people who might be stressed. So, people come in to see the doctor and they're nervous about getting a shot and they're scared. And so they will have their pulse might run a little high. It might be 106, 108. And you're like, are you feeling okay? Everything's normal. They're like, yeah, I'm just nervous about this. Or pain can raise your pulse. So there's a lot of things that can throw it out of range. And so same thing with blood pressure. And so that's why, technique and all of those things, is really important. And I guess I would also say the context of which we're doing something. So if somebody is not well and they're feverish and ill, and I'm concerned that they have pneumonia and their heart rate's 107 or 110 or 115, and they normally are not like that, then I'm a little more concerned. So a lot of the decisions I make on whether or not so we have something called vital signs, right? So pulse is one of the vital signs. A lot of the decisions I make regarding whether or not I consider those readings normal and benign or flagging a concern are going to depend on the clinical context. And so that's why a lot of things need to be interpreted by a medical professional, because it's all about the clinical context.
Mm.
So
is the pulse the one where you put your finger, when you do this manually?
Yeah.
And then you kind of count how many beats per minute? Is that what the pulse?
Yes, correct.
Okay. Remember
they call that
Sandra.
the poor man's lie detector test.
Well, you know what? The pulse tells you a lot, but it doesn't tell you everything. Like I said, I mean, I can have, I like to see a lower resting pulse in healthy people if they're not on certain medications, because it can indicate better cardiovascular conditioning, right? So I always joke with people, like the way I think of it, of course this is not true, but it's like your heart has gotten so efficient, it only needs to beat once a year. That's not really true, of course. That doesn't exist, but it just means that your heart has become, like your cardiovascular system has become very efficient. So it doesn't need to work as hard. And so that's an easy way to look at it. And now that's different if somebody's taking like a blood pressure medicine, like a beta blocker that can slow your pulse down. So you can have somebody who runs around 55, they're not in good cardiovascular shape, It's just because they're on the beta blocker. I see another hand.
When do you start feeling lightheaded when you have a low pulse can cause that, right?
Correct.
Or dizziness.
Also, hard to tell.
Local.
Like there isn't like a number for, if you come in and your pulse is 32 and you feel lightheaded, dizzy, I'm automatically extremely concerned. I need to make sure that you don't need a pacemaker at this moment.
Wow.
But if you come in and you're feeling lightheaded and dizzy, and I'm going to tell you as a physician, that is probably one of my most hated, like, complaints. I feel dizzy because the medical definition of dizzy and the layperson's definition of dizzy is different. But their pulse is 72, and if I run an EKG and it shows it's a normal rhythm and they're currently feeling dizzy at this moment, then I can say that the dizziness is probably not from a low pulse.
Okay. What causes low pulse?
Well, as I was saying, physiologic low pulse versus pathologic low pulse are different. You can have a physiologic low pulse in a well-conditioned athlete. So I'm going to guess that like Olympic runners and all these things, they probably have a resting pulse of like 48 or something. And they're fine because they're athletes and their heart is trained to become very efficient.
Wow.
You can have medications that can lower your pulse rate. Another point in my life, I have a history of migraine headaches, and I had put myself on a beta blocker to help treat that, to prevent them from coming. And I was feeling like garbage. I'm really tired. I'm just really tired, and I just don't feel good. And I was like, it's just, just life and all those things. And then I finally checked my own pulse. It was like 41 or something. I was like, okay, maybe this is not the best medication for me.
Wow.
So yeah. And, so that can absolutely happen. And then you can have people who have intrinsic problems with their heart. So something called sick sinus syndrome, where the natural pacemaker, the heart, is not working normally. So the way your heartbeat is generated is there's an area of cells on the left atrium of your heart that are called the SA node or the sinoatrial node, and they have an intrinsic rhythm to them. They have this intrinsic rhythm where they spontaneously depolarize and send an electrical discharge through your heart muscle to cause that contraction. And in some cases, that just doesn't work anymore. And so that's often when patients have to have a pacemaker placed. So I have had a patient who came to me. This is an older person and had a heart rate. There you go. Had a heart rate of like in 30s. And this is a person over the age of 65. And I'm like, why is your heart rate so low? And the person said, well, I don't know. My cardiologist says it's fine. I'm like, I don't think that's fine. And the EKG was fine. Do you have any symptoms? No. Very active person. But also told me at the same time, I don't have any heart disease despite being on a couple of meds. And I'm like, okay, let's send you this person was new to the region. And so I sent this person to a local cardiologist, and yep, there's heart disease, and yep, there's a rhythm problem, and they ended up getting a pacemaker placed.
Wow. And what is a pacemaker? Can you just explain to?
Yeah, so pacemaker is an implanted device that generates an electrical. It is implanted into the chest. There is a generator or battery pack, you can say, that you can feel. It's usually nowadays they're in the upper chest, and they're underneath the skin. They're placed surgically. They're placed there, like they put it in, stitch you up. There you go. That's exactly the picture. And it sends an electrical wire to the area that you want to have this spontaneous rhythm creation, and it causes an electrical impulse that spreads through the heart so that the heart can contract normally. The pacemaker helps prevent the patient's heartbeat from going too low. When it goes too low, you're not circulating blood through the brain. And then when you don't circulate blood through the brain and the body, you're going to pass out because you're not getting enough blood flow. So the pacemaker does that for you. You can have some that are like constantly on and some that are like on demand. And then that pacemaker battery has to be replaced every few years, but it's a relatively minor surgery. They don't take out all the wiring. They just take out the battery and just replace it and put a new one and you're off to go.
So that pacemaker is that small?
They're small. They're nowadays I would say, I don't really know. I haven't handled one in a long time. Like the size of probably like a old fashioned matchbox. Yeah, like that. They're not very big.
So what if in the middle of the night, like your pulse goes down? Is that possible? Like while you're sleeping?
Well, you do have, like all of your nervous system kind of, just a general way to look at it is it all kind of quiets down when you're sleeping.
Okay.
So if your pulse is going to go lower when you sleep because you're laying there, you're not exerting yourself at all. So you kind of need just like minimal circulation, to kind of maintain systems. It's like standby.
Okay, so like the computer goes to sleep.
Yeah, kind of.
Okay, so that it's... Okay.
And that's actually not true. I mean, it does change. It does vary with the sleep cycle. I will also say that it's not like you go to sleep and then everything goes to low gear and then it stays like that until you wake up. Not really, but you will have more lower tip in a normal healthy person, lower heart rates and blood pressure through the night.
Okay. And typically. So someone's pulse rate goes down too low, goes to like, I don't know, 30, 40, whatever. Again, you said 30
25.
is the ER.
Let's say 25.
Okay.
Let's just make it something horrible.
Okay. That's 911? Or just get up and run?
It depends on what the patient looks like and whether or not you have an EKG. So, if the patient is symptomatic, they're short of breath, they're having chest pains, they're going to pass out, they've passed out, they've fallen, they're not with it, that's a medical emergency. They need to be transported immediately to the emergency room for evaluation and probably need an external pace replaced at the very least while we try to figure out what happened.
Okay.
So there's different degrees of something called heart block. So heart block is when you have problems with the transmission of that electrical impulse through the heart muscle. So there's problems with it. There's something called first degree heart block, which means the impulse goes through, but it's just kind of a little bit delayed. And that means nothing. That doesn't lead to anything. It's just you have first degree heart block. Thank you very much. In general, I will watch you a little closer as a primary care doctor, but it's not, I want to make sure there's nothing else going on, but it probably isn't. Then there's other types of heart block where you have what we call second degree, where you sometimes will have impulses go through fine and then some that don't go through at all. And there's different types of those, and some of them are benign and some of them signal underlying pathology. I will generally have you speak with a cardiologist, and how urgently that is depends on if you're symptomatic and how long we think this might be going on. So once again, a lot of things are in the clinical context. So that patient that had come to see me who had a pulse of like 32 or something like that, when you look back at the records, like this has been going on for a long time and the patient is well. So I don't feel like you have to go to the emergency room right now, getting an EKG just to make sure there's nothing that's changed. But other than that, like, let's just get you into cardiology urgently. It isn't something that, like, so it's all about clinical context. Now, if we have records on you that show your typical pulse is 68 and now you're tired and you don't feel good and you're dizzy and now your pulse is like, you're going to the ER. So a lot of it is clinical context.
So is it that
and a lot
serious?
Of it,
I mean,
yes, it can be. It can be. See, that's the thing is,
you might as well go to the ER, right?
Well, you know what?
No?
It depends. Like you're asking me to cast a decision on something that, like, hey, everybody's pulse rate of this is definitely disease, go to the ER. Well, once again, if it's always been like that, then it's not an emergency.
Yeah.
You know, so in another case, I had a patient who was having an asymptomatic EKG done for administrative reasons, right? So this wasn't for a medical concern. This was a healthy person. I ran the EKG and they had something called third degree heart block, which is complete dissociation between all of the electrical components of the heart, like that whole SA node and all that pictures that we're talking about.
Yeah.
there was a complete disconnect between the heartbeat of the ventricles, which power the blood out of the heart, and the heartbeat of the atria, which kind of get this whole party started. Complete disconnect. That is an indication for an emergent pacemaker. But I looked at this patient, like, how do you feel? Like, I'm fine. I'm like, okay, here's your EKG. I need you to proceed to the nearest emergency room. but the patient is like, they've probably been like this for a long time. Now, I've never seen asymptomatic third degree heart block before or since, but there are times when your low heart rate is a problem. Now, this person's heart rate was low normal. I want to say it was like in the 50s, but it's been a while. I forgot.
Oh, that's complex. So,
very, very, it's not as simple. So when you ask me what's too low, it depends on the context.
Yeah. The device that, I showed on the screen,
the pacemaker.
No, this one right here. Is this all the device you need to kind of, let's say, I'm living with my parents and kind of run this, do a blood pressure test on them, see their pulse. And is that kind of all you need to understand what we're talking about? Whether, hey, something's wrong or that's actually normal?
I mean, those are you need standard vital signs that kind of give you a good clinical picture, and blood pressure and pulse is part of those.
Okay.
But to get a full clinical picture, then you need also respiratory.
Oop, we lost her.
So, well, I guess when you're saying, because what I'm seeing is on the front, what's displayed is cardiac arrhythmia. Is that what you're referring to?
Ooh, no, I'm actually just displaying like a blood pressure device.
Oh, well, okay. So like a typical blood pressure cuff, right? So a typical blood pressure cuff, an electric one that goes on your arm, right, will typically also measure your pulse. If it gives you a pulse in the 60 to 100 range, that is a typical pulse for you, and everything is fine, that can be reassuring. It's like, okay, well, we know that's not the problem, right? But sometimes it's, if it was just about collecting hard number data and then that would be it, then that gives you an answer, then this can't work like that. It's all about the situation. If somebody has so that picture right there, the pulse is 79. If this is a person that typically runs 50, then why is it 79? It might be not anything serious, or it is something very serious. Or if this person I have a patient who I've seen recently who typically runs almost 120 for the pulse, and I'm like, everybody thinks this is okay, including your cardiologist. I don't think this is normal. But if this person walked in and had a pulse of 79, I'm definitely going to be like, hey, are you okay? Like, is everything normal for you?
So I just need to know what, when I see my parents, I need to have this. I need to have a glucose test.
Yeah. Well, also it's helpful to learn how to count a pulse manually. I think that's something everybody should learn how to do. It's not that hard.
What's the best practice
for counting a manual pulse?
It, First, like, stay away from squirrels. Do not look at squirrels.
Well, I no, you just put your hand on their pulse, and then you count for how many beats you feel in 10-second period of time, and then multiply it by.
I actually
wait. You're hold on, Dr. Ray. You cut out. Wait, say it again, and then tell me, Dr. Foss, whether you agree or not. We're cutting out.
I will just go ahead and replace. I'll just say, Dr. Ray, can you hear us okay? It's like a seance.
Wait, Dr. Ray, you're cutting out. Cut. All right, Dr. Foss. Is this photo seen on the screen correct?
Yes, I would say it is. I would give it. So what's right about it is it's in the approximate location of the radial pulse.
Okay.
And then it's also correctly being done and that they're using not their own. Well, if you're counting your own pulse, you can use your thumb, but you should not use your thumb to count a pulse if you're counting somebody else's pulse because you may feel your own pulse.
Oh, okay.
That's why you should use your index and or middle fingers to do it. But I actually think that feeling the radial pulse can be difficult in some people. So a great way to just feel your pulse is put your hand on your chest. If you can feel your heartbeat, you can just count it that way. That's one way to do it.
Oh, okay. Okay. And then what is this counting and multiplying and dividing?
Yeah, see, the reason I respectfully disagree with Dr. Ray, who I have mad respect for, is that we can do that. Like I can count your pulse and estimate it and multiply it by 10, whatever. But
Yeah.
I think that a lot of patients won't get that number right. I also think when you have potential for irregular heart rates or rhythm problems, you might not have a true rhythm. So I usually recommend that people count it for a full minute and then just you have to have a clock, a sweep hand, to do that. But to take the math out of it, just count it for a full minute.
So tell me about this photo on the screen.
So it looks like that we are looking at different places that you can feel the pulse. So typically, easiest places to check pulses, right? Like where we examine people, is the radial artery in the wrist, which is on the thumb side of the wrist and not the pinky side of the wrist. Okay.
Okay.
That is a classic place that the pulse is checked because it's easy access and easily, like somebody's sleeve is usually not over it, like you can get to it. But if you push too hard, it can be hard to feel. And there are some people where that's just hard to feel. And like it'll be generally in that area, but not necessarily in the exact same point for everybody. You can also check another, like I said, so when they have the picture of that chest right there that says apical.
Yeah,
that
why does
really
it have
refers,
3 nipples?
Did you know a large portion of patients have accessory nipples?
Really?
Yeah. They sometimes look like, they'll be like, almost like a mole looking thing. I saw the faces on that sort of, it'll be like a mole looking thing that'll be in what we call the milk line. It'll kind of like be in line with the nipple, but usually lower on the chest or onto the abdomen. It's actually not that rare. I've seen several, and they don't look like full blown nipples with like an areola and all that thing, but they'll be like a kind of like a mole that sticks out like in the nipple line, and you're like, oh, it just looks like an accessory nipple.
See, a squirrel just walked by, and we just got completely distracted. All right.
I'm telling you. So back to the boring stuff. So that apical picture, which I can't tell from this magnification, I can't tell if it's 100% accurate, but basically, the peak of your heart, like, so like, kind of like where your heart sticks out. The heart isn't really heart shaped like Hallmark would have you believe, but it kind of has a pointy end, and that pointy end sticks out closest to the skin. It would call the PMI, or the point of maximal impulse. And that is kind of around that nipple line-ish in that general frame. So that point of maximum impulse is what we call it, or the apical pulse. You can put your hand there and sort of see if you can feel your heartbeat. Once again, easier in some people than others. The next classic place to feel somebody's pulse is in the kind of like the hollow of their neck. So that would be the carotid pulse. That's a little low in that picture that's being displayed, I would say. Once again, I don't have the best view of this, but, it's kind of like in the hollow of your neck right there, and you want to be careful to not rub it or massage it, and you certainly don't want to check both at the same time, but that is a place that you can often feel a pulse. I'm sure that you all are doing that right now. And you should be able to feel your pulse there. So that's actually a fairly large, easy to palpate pulse. And an important point to know if you like ever have to do CPR on somebody or BLS. And then where we measure a pulse, just because we have all talked about blood pressure ad nauseum, I have to throw it in there again. Is the brachial pulse, which is what your blood pressure cuff and what we do when we do a manual blood pressure cuff. That's where or blood pressure check. That's where we are listening. Is we're listening for the brachial pulse, which is inner part. So it's above the elbow crease, just inside of that big biceps tendon. It's in that general vicinity. And sometimes it's deep for some people, sometimes it's more shallow, but that's another large pulse point. There's some on there's the femoral pulse, which is in the groin line. There is the back of the knee. There is, I check a lot of posterior tibialis pulses, which is just kind of behind the ankle bone on the middle, like the middle ankle bone, like the mid ankle bone, not the outside ankle bone. Yeah. And the top of the foot, the top of the foot is the dorsalis pedis pulse, and I definitely want to check those in my diabetics. And that kind of gives us an idea as to circulation. No, I will say some people have more difficult to feel pulses in certain parts of the body. It doesn't necessarily mean it's a disease, and that's where the assessment of a medical professional is important. Because you know how many posterior tibialis pulses I've checked in my lifetime? I don't know, 10,000, a lot. Wow. A lot.
Wow.
So there's a lot of, I guess it comes down to this. There's a lot of places that you can feel it's like the downstream flow of the heartbeat. That's what the pulse is. It's when the heart contracts to squeeze the blood forward. I can feel that wave as it travels out to my arm, let's say, and I can feel it in my radial pulse at the base of my wrist.
Well, that's good to know. I mean,
it is more. I mean, this way, you know why it's good to know how to do it manually? Because if you don't have a machine handy, you can just count somebody's pulse.
Yeah. 100%. I mean, especially when we're with our senior citizen. If I'm around my parents or their friends, then kind of like know where to feel their pulse. But avoid the apical. That's just a little bit.
Well, putting your hand on somebody's chest is probably the most direct way to do it.
Oh, really?
Yeah, but a lot of times, like when you find somebody non-responsive and down, you'll see a lot of people putting their ear to the chest to hear for the heart rates, because sometimes you can't always feel a pulse, but they'll put their ear to their chest to actually hear if the heart is beating or not before they begin CPR.
Wow. Learned something new. I learned something new. Anyone else have a question? Any other comment before we get distracted by a squirrel?
No, very informative episode. I learned a lot today.
From pregnancy to...
you guys, when you join us every week, you're going to med school. How do you feel about that?
Exactly, yeah.
I feel exhausted.
That is so wild.
I feel exhausted. That's entirely appropriate.
Yeah.
Now, Dr. Ray, you're back. There was a delivery. What's going on?
I did have to step away for a delivery. A patient who I delivered, she progressed a bit quicker. According to the nurse, when I arrived, her bag of water broke. It was her third pregnancy, and as soon as the bag of water broke, she was ready to deliver. She did not have an epidural, so she's what we call unmedicated, and those patients tend to go a little bit quicker, but also are in pain and discomfort and are kind of screaming out in pain and everything. So luckily, like I said, I'm here in the hospital, so I just ran down the hallway for a couple of rooms and was able to deliver that baby quickly, and all is good.
We're already back. We were joking that it wasn't a regular delivery, it was a DoorDash delivery.
And then now I'm back to podcasting, so.
That is wild. Well, we will end this, and please get some food, and good luck to the women that you will be helping today, and the babies. We welcome them, Any closing remarks, Dr. Ray, Dr. Foz? Dr. Ray, let's start with you.
No, just sorry about the technical issues and speaking in and out. So hopefully next week will be better. But trying to, juggle and manage many things as most people are nowadays. So trying to honor my commitments for the podcast while still, doing my job responsibilities. So.
No need to be sorry. That was really awesome that you could join us and do this and, spinning 1,000 other plates. Dr. Foz, any closing remarks?
I'm just incredibly impressed by how well she pivots between these wildly different things, like, bringing a new life into this world and then talking to us.
Right. When you travel with Doctor, you get so much things done. You're like, God, we saw 100 things today.
The efficiency, amazing.
You have to be efficient. You have to be efficient and to get things done for sure.
Wow. So, when you left, we're like, delivery! All right. Well, that concludes this episode, and we hope that you enjoyed and learned a lot. Go get your blood pressure device. And
get your blood pressure screened.
Okay, and we're gonna just practice, counting our pulse.
All right. Take a CPR class. That's something that the layperson can do, and you might be able to help save somebody's life.
Oh yeah, definitely.
Well, there you go.